You should see that now. So I'm Sharif Gurnham. I'm one of the respiratory consultants in Nottingham and lead for asthma. And I wanted to talk to you about the service that we run and particularly about asthma biologics, which some of you may have heard of. So I'll talk about the services that we run, the consensus pathway that's been published recently on management of uncontrolled asthma, and about biologics and the drive to improve uptake. So just a few key facts. About 5.5 million people have asthma in the UK, and about 1 million have difficult to treat asthma. But of those, 200,000 are estimated to suffer from severe asthma. And later I'll talk about the difference between severe and difficult to treat asthma. It's thought that about 60,000 people in England may benefit from having asthma biologic agents, but only about 11,000 are currently receiving them. So currently, there are 13 nationally commissioned severe asthma centres in England, each with a regional MDT, and Nottingham is one of them. And we operate a hub and spoke model, which means that Nottingham acts as the hub, and there are various other hospitals in the region in Nottinghamshire and Lincolnshire which act as spokes, and we take referrals from them. And they include Kings Mill Hospital in Mansfield and the hospitals in Lincolnshire, Lincoln County, Pilgrim and Grantham District. And within our direct or closest patch, we also take direct GP referrals from South Notts and City. So what happens if a patient comes to us? We do a multidisciplinary assessment. Patients get seen by not only one of the consultants, but also an asthma specialist nurse. There's input from pharmacists in terms of checking their medication adherence. Patients can be referred to physiotherapists or speech and language therapists if needed, as well as ENT surgeons or psychologists. And then we have access to advanced diagnostics, and we are authorised to prescribe and administer high-cost biologic therapies. So the difference between severe asthma and difficult asthma is that difficult asthma or difficult to treat asthma encompasses a whole host of factors that can impact on asthma control, including poor medication adherence or inhaler technique, psychosocial factors, dysfunctional breathing, vocal cord dysfunction, and so on. Whereas when we talk about severe asthma, we're talking about truly refractory disease, so asthma that remains uncontrolled, even if you correct all of the above. And these are the patients who have severe biology underlying their asthma, who need biologics to control their disease. So just briefly to mention the BTS asthma guidelines, which have the stepwise treatment for asthma. And as you move up the steps, really once you've gone above medium dose inhaled steroids, added in montelukast, added in a long-acting beta agonist, that's when you should be starting to think about getting advice from specialists, even if that's an advice and guidance in the first instance. And these are the current Nottinghamshire guidelines, and you can see the various medications that are recommended at each of these steps. And as you can see in the bottom right, you've got referral for specialist therapies for any patient needing more than 2 courses of oral corticosteroids per year, so 3 or more. And in the top right, you can see some additional add-on therapies which are on specialist advice only, and that can be via advice and guidance if needed.
Sharif, I'm sorry to interrupt you. Is it possible if you could zoom in slightly? I just can't quite read the text. I'm not sure if others might be struggling a little bit. Perfect, thank you. I have got my glasses on, but I still couldn't see it. Thank you.
That's fine. Hopefully that's a bit easier.
Lovely, thank you.
So this, I'd highly recommend this document to everyone. It's just come out in the last year. It's a consensus pathway that's been put together by a whole host of stakeholders in the asthma world, including the BTS and Asthma and Lung UK. And it really covers the pathway that patients ideally should follow from primary to secondary to tertiary care if they've got uncontrolled asthma. So, I mean, just briefly, it covers what should happen in primary care, secondary care, and tertiary care, and what are the indicators of uncontrolled asthma that should be a trigger for referral. So, pretty similar to what I mentioned before. So, any one of 2 or more courses of steroids for asthma, 1 or more hospital admissions, 6 or more SABA inhalers, or poor symptom control as assessed by a validated questionnaire. Or if patients are on maintenance steroids for their asthma, which is something that we really want to avoid nowadays. So I won't go through this in great detail because I know we're quite short on time, but I'd recommend going through that document. So just going on to biologics, these are molecules that target the asthma pathophysiology.
All right. No problem. Thanks.
I think there might be someone unmuted at the moment. So these target various cytokines in the asthma process, such as IL-4, IL-13, and IL-5. And the most commonly used ones at the moment are omalizumab or Xolair, which we've had for about 10 years, and then the anti-IL-5s, mepolizumab, and we normally use benralizumab. And these are all given by subcut injection, usually between every 2 and 8 weeks. And we tend to teach patients to inject themselves with this. So just like an insulin injection, after the first few injections, patients will have the injections delivered to their door and they will administer it themselves. And some of the evidence behind the efficacy of these, this was one of the first studies that was done on mepolizumab, showing that over a 1-year period, it reduced cumulative exacerbations by about 1/2 compared to placebo. And then the other main benefit is allowing patients to reduce their oral corticosteroids. So this is a study showing that patients who were dependent on daily oral corticosteroids were able to reduce these on benralizumab, whereas the black line, the placebo arm, they attempted to reduce but really were unable to do so, and by the end of the study they'd only reduced by about 25%, whereas the biologic arm had reduced on average by 75%. And despite reducing their daily oral corticosteroids, patients in that same study still had fewer exacerbations if they were taking the benralizumab. So in the last couple of years, improving the uptake of asthma biologics has become a national priority, and 8 projects were funded in England, and we were awarded one of these to try to improve access to severe asthma biologics. So this project actually is just finished, although we do have some additional funds that were given to us from East Midlands, AHSN and the ICBs to allow some of the project activities to continue until the end of this financial year. So, I mean, briefly what we did is we introduced enhanced case finding in primary care using bespoke tools. So in Nottinghamshire, we used eHealthScope. In Lincolnshire, we used something different called Spectra. A lot of you might be familiar with eHealthScope already, or may have come across this search tool that's been developed by a couple of GPs in our region, Stephen Wormel and Mike O'Neill. And this also ties into a fast-track referral pathway. So patients who come out from this search can be referred to us. You can send the referral to myself, my email's at the end, or to Gemma Bellis, our administrator. And we do have access to community MDTs. In other words, if you'd like to discuss the case rather than referring directly, then we can arrange that via a community MDT. In Lincolnshire, we did actually appoint community asthma nurses to do some of the patient reviews. We didn't have the funding for that in Nottinghamshire, which is why we're taking direct referrals in that case. We also did some educational sessions, and we increased our capacity to see extra referrals in secondary and tertiary care. So in terms of achievements and challenges from this project, we did have a high level of engagement from primary care. We achieved greater integration with secondary care. We've managed to undertake the eHealthscope searches in most of Nottinghamshire now, all of Mid Notts and a lot of South Notts. In Lincolnshire, the community respiratory nurses were very effective and impactful. We've been hoping to get something similar in Nottinghamshire, although not yet got the funding for that. Challenges, well, going back to last winter, it was difficult to make progress just because of the pressures that everyone was under. I think it has been challenging to get the funding to continue beyond March 2023, but we're still working on that. So take-home messages. So we've got the specialist asthma service on your doorstep. We cover 2 counties. We offer a multidisciplinary service and access to biologic therapies to patients who are eligible for them. The main benefit of biologics is reducing the burden of oral corticosteroids. So the patients that would particularly benefit are those who are either on continuous oral steroids or are having frequent exacerbations, 3 or more in a year. And if patients aren't optimized following 6 months in primary care, then please refer them in. And there is the eHealthscope search tool available for case finding, which anyone can use in Nottinghamshire. And I'll put my email there, so if you have any questions about our service, then please drop me an email. Great, thank you. I'm happy to take any questions.
Thank you, Dr. Gonham. We really appreciate your time coming to meet with us and for allowing us to record it for colleagues that haven't been able to make this. It's really appreciated. Does anyone have any questions at all for Dr. Gonham that they'd like to ask while we have him at the meeting? Dr. Kerry Salis is also in the meeting. Kerry, I don't know if it would be helpful for you to also explain your CDA role and what that means and how you've been working collaboratively together. Hi, Kerry.
Hi, sorry, it froze a bit. Yeah, hi everyone. Apologies that I was a little bit late. Had the dreaded 1-year-old vaccine, so I'm obviously the devil to my son at the moment, so I've just had to dump him over. So yeah, so I think, you know, working sort of with the biologic team and things, you know, it's sort of trying to look, you know, moving towards that sort of ICB structure that we have now and working together. Sharif, I'm sorry, because I was in a little bit late. Is the number still open for direct referrals into the specialist nurse or not? Because I know we haven't had a chance to touch base recently with regards how practices can refer in. I don't know if you said it at the beginning, I'd maybe missed it.
Yeah, so there is the eHealthscope tool, and I mean, I can send some details through to be circulated. That's probably best because I can see someone in the chat asking about that. There is an F12 referral form that comes with that that you can complete and just email to us. If you email it to Gemma Bellis, again, I can send those details through. Then we can take those referrals. I mean, what we ask is, please could you check that patients are actually taking the prednisolone for their asthma, because I did get one referral recently who they did have asthma, but they'd been taking the prednisolone orally for lichen planus in their mouth. So they've just been taking it topically dissolved in water. So quite unusual, but most of the patients that we've had referred have been very appropriate actually, and we've been able to improve their treatment, and some of them will be sort of moving forward for biologics, I'm sure, in due course. So that's the referral pathway essentially. It's completing that F12 referral form and emailing it to us.
Real, thank you. Okay, so if there's no other sort of questions for Sharif, I'll quickly move on to my bits. I don't think, is there someone with a hand up? No, okay.
Further questions. Thank you, Dr. Gonan, for your time. I really appreciate it. You're very welcome to stay while we debate the diabetes local enhanced service, but I'm conscious that you've got probably lots of other things to do.
That's fine. Thanks for having me.
Thank you.
Bye for now.
Bye.
Before I jump on with that one, is it all right to do the other bit I wanted to do with respiratory, if that's okay? So yeah, so for anyone that doesn't know me, I'm Kerry. I'm a GP. I'm part of the Clinical Design Authority for the ICB. The areas that I work with the system are respiratory, diabetes and CBD. So majority of the long-term conditions. I've just got a very, very, very quick, hoping I can share, just update on self-management plans. This is just something else that we've been sort of looking at as a system. So I'm hoping, has that come up? Sharing, brilliant. Yeah. Very quick with this. So this is something, again, that's been co-designed, excuse me, across the ICB, looking at self-management plans. If you think about whole commissioning footprints and how we work, how many times is it that there are different self-management plans that are used, they're not shared? So what we try to do as a system is not to reinvent the wheel and try and just do one thing once, if we can. So we've looked at sort of revitalising the self-management plans. So here are the links, if anyone want them, they're on GP TeamNet. We've got the agreement for community teams to use them. These have been embedded into the general practice systems. I've got some snapshots of where they are. These slides will be circulated, but I can quickly go over them to find them. On discharge for patients, if they're given a self-management plan by any of the trusts. Basset law is a work in progress, just obviously, as you can imagine, with the creation of the ICB and them joining us. But hopefully there is one self-management plan for the patient rather than lots of different ones. So essentially, for anyone that hasn't looked at them, these are what they look like. We've got the red, amber, green with regards to scoring. Just a little bit of information for anyone that doesn't know, for every 5 properly filled in self-management plans, it can sort of help a patient with 1 admission avoidance. So that's obviously quite a big impact for the patient. Again, like I said, these will be circulated. So with regards F12, here are the areas of how you can look to fill it in. Again, moving through, but like I said, they'll be circulated. That's for system 1, which I'm more familiar with. This is where you'll find it on EMIS. I don't use EMIS. So if anyone has a look and they can't find it or they're struggling, please let us know. And then we can link in with sort of how to find it. And that's that, nice and quick, because I really want, I feel that there's going to be more feedback and questions with diabetes. So I wanted this to be super, super quick. Stop sharing. Does that stop sharing now?
Yes, thanks, Kerry.
Okay, so from a respiratory